Okay, well, hello everybody, and welcome to the February webinar of Northwest ATTC. Let's get started then. So I'm Bia Carlini. I'm the Northwest ATTC webinar coordinator and also a system change specialist. As the slide says, questions will be taken at the end. You have a little chat box that you can, type a question anytime. We are going to take them in the end. We usually get this question a lot. We will have the presentation and the slides available for our website right after, as we finish the presentation, it will be there. It takes about 24 hours for us to have ADA compliant recording, but it will also be available the same way. We would like to get started then, but let's get some housekeeping. I'm not being able to change. Okay. Okay, now we are going to go directly to the presentation. So I would say we could not find better speakers for the topic of trauma addiction than we have today. The two speakers are from Oregon, and I'm going to briefly introduce them to you. So Mark Girard is a psychoanalyst and a clinical social worker with a private practice of more than 20 years in Oregon. Mr. Girard was trained in Zurich in the Young Institute and later in Simon's College School of Social Work. He has a long trajectory both supervising other therapists, both locally and internationally, and also serves as a therapist in his private practice. Mark specializes in working with the underlying psychodynamic, symbolic, and somatic process of chemical and behavior addictions. Our second speaker, our other speaker, is Dr. John Fitzgerald. He holds a PhD and is the Statewide Addiction Treatment Analyst for the Oregon Criminal Justice Commission. He's presently leading our work on the Senate bill that involves studying, tracking, and accounting for all public money spent in addiction treatment in Oregon and the outcomes achieved with this money. Dr. Fitzgerald also maintains a clinical private practice in Oregon and presently is clinical faculty of the Department of Psychiatry in Oregon Health and Sciences University. So without further ado, thank you so much. We are now transitioning the slides to the speakers. It usually takes a little time to do this transition. Welcome.
Thank you, Bia. This is John Fitzgerald, and I'm with Mark Girard. And we are here in Lake Oswego, where it's quite snowy today. Snow is coming down outside us right now. I'm quite grateful that Mark was able to make it here so we can do this together. We realize that the topic treating co-occurring trauma and addiction, as well as opioids, alcohol, and public health problems is a lot to get through in about 45, 50 minutes. But our goal is to try to hit 2 or 3 points that will be most useful for you as clinicians. I want to start by saying on Monday night, I was at Madison Square Garden in New York City, and I was listening to the rock band with my son, Disturbed. It was the first time that they headlined Madison Square Garden, and their latest album, Evolution, has a number of songs related to addiction. David Draymond, the lead singer, struggled with addiction. And at one point in the show, he had the house lights come on and he asked everybody, without shame, to raise their hands if they have struggled with addiction. And it was an unbelievable sight to see how many hands went up. Now, granted, they're a bit of a self-selected crowd going to a Disturbed concert, but he then went ahead and sang the song A Reason to Fight. And one of the things that he talked about was the idea that people who are really fighting for their lives, in some ways really don't feel like they have a chance, that they've really struggled. They have a tremendous amount of hopelessness. And in some ways, part of what we're talking about today as clinicians is how to give people who are really struggling with a lot of stuff hope for the future. Both Mark and I have been doing this work for and really believe that trauma and addiction are treatable, and that a big part of our work is providing patients hope.
So John talked about hopelessness, helplessness, no way out. I'm stuck in a hole, despair. So despair is often at the core, despair about themselves, despair about other people, despair about the world, and how to relate to that despair in a constructive, creative, and in the end, a relational way, both with yourself as a clinician and then you with your clients. That's the key, in an emotional, steady, consistent, creative, relational way.
I think one of the places, still getting used to the button here, one of the places that we want to start really is the idea that a lot of the work that we do is about relationships. Many of you may be familiar with this TED Talk that Dr. Waldinger, he's the director of the Harvard Study of Adult Development, did on 2015. And this is really about the longest study ever done on happiness, where they tracked over 700 men, and part of them were from poor neighborhoods in Boston and others from Harvard, really looking over many, many decades at what were the various contributors to a good life. And for those of you who've seen this, you know the outcome, which is that it's relationships. There's also another project that involved women called the Longevity Project, where 1,500 Californians were tracked over 8 decades. And again, there were similar findings that a good life is about relationships. And in some ways, that's the end point. That's what we're trying to do with the work. And yet, part of what gets in the way of healthy, intimate relationships is trauma and addiction.
Let's just read this kind of out loud and let it sink in for a moment. It's by Besser Pentacle. Trauma, whether it is a result of something done to you or something you yourself have done, almost always makes it, quote, difficult to engage in intimate relationships. After you experience something so unspeakable, i.e. despair, that's me, how do you learn to trust yourself or anyone else again? Or conversely, how can you surrender to an intimate relationship after you have been brutally violated? So again, the sense of kind of chronic and acute despair, and how do you hold that sense of hopelessness within you? How do you cultivate a response to the hopelessness, to the helplessness, to the despair, if and in some ways at your core, especially with developmental trauma, your sense of well-being in the world, and then really with yourself is compromised. Again, on a continuum, that's part of the assessment process. John?
Yeah. So I want to talk, we're in kind of the first part of this talk really about the nature of the problem. And one of the things that helps us to kind of frame it is what we've learned from a variety of different studies, particularly around the neuroscience piece of this. And in 2003, we mapped out the human genome. So we learned a lot about the building blocks of life. And now what we have is the Human Connectome Project, which is really about constructing a map of the complete structural and functional neural connections in vivo within and across individuals. This is the first large-scale attempt to collect and share data of a scope and detail sufficient to begin the process of addressing deeply fundamental questions about human connectional anatomy and variation. And so we're really now in this project getting at a point where we're starting to look at the connections in the brain, in these different systems that start opening us up for having a better understanding of the disorders and treating the disorders. There's a book called Connectome that by Sebastian, I think Sohn is how you pronounce his last name, that is sort of really a nice read about opening up sort of what the future holds for us. But I think in some ways, we know a lot right now about trauma and addiction. Sorry, the slides are, where is my button to go back? Hey, Bia?
Can you try like the left arrow key on your keyboard?
Okay, let me see if I can do that. There we go.
There we go.
All right, I'll use the keyboard. So going back, one of the things about the neuroscience today is we know a lot about trauma and addiction already that I think is helpful for us when we're starting to talk about treatment. We know that for trauma, that both parts of the amygdala for emotion and different parts of the brain related to memory systems, the hippocampus, are involved in trauma. We also know that similar processes and parts of the brain are also involved in addiction. One of my colleagues, Dr. Eric Nestler, he is the director of the Friedman Brain Institute at Mount Sinai. And during the last year, we've had a couple occasions where I've been able to interview and talk with him about trauma and addiction. The last time that we met, I had some papers mapping out kind of what we knew about trauma in the brain, as well as addiction. But part of our conversation was really around why there haven't been more papers integrating what we've learned from both of these. And the answer is that funding streams really are separate, that when you look at the way that work is being done right now in laboratories and by different scientists, it really is quite fragmented. And yet in his work and at Mount Sinai, one of the biggest take-homes that he left me with was that these disorders are very, very much integrated in the brain, and that we need to, when we think about treatments, really start moving in a direction of more integrated treatments. Kind of there's a couple big take-homes that we've learned from some of this work in neuroscience. On the trauma side of the equation, which is on the left here in this slide, this is an image that comes out of Bessel van der Kolk's book on The Body Keeps the Score. But the limbic area, the visual cortex that's red, these are the areas that light up in the brain related to emotion and being able to see images in the past related to flashbacks. One of the big findings out of their imaging studies was the fact that Broca's area shuts down. That's the yellow area. And so in the book, he calls trauma a speechless horror, that people have a very challenging time putting into words the nature of the problem. On the right-hand side, what we also know is that when people go down the path of addiction, and 80 to 90% of people go down that path prior to the age of 15. So in some ways, this is a disorder of adolescence that gets played out in teenage years. And as people are going down that path, I think it's important to realize, nobody sets out to struggle with addiction. Alan Leshner, the past director of NIDA, used to say nobody sets out to get heart disease. They just like fried chicken. And I think it's the same. People experiment when they're young with drugs, with alcohol, with gambling, with a variety of different things. They don't set down the path to hijack their brain. But there's a variety of things that happen over time, a variety of risk factors and protective factors that help us to understand that at some point the brain does get hijacked. And when it does, and we neuroimage it, we do know that those who struggle, their brains are different. They've changed. Eric Nestler is really been key in helping to understand how that happens through mapping out the protein of delta phos-B, which is really kind of the switch that gets flipped in the brain around being hijacked. But again, part of what he really wanted me to take home was the idea that now their work has shown that there's multiple switches in the brain, and that again, trauma and addiction are integrated as two problems.
John, can you go back to the brain image?
Yep.
And so with this, one way to take the fragmentation, John talked about the fragmentation, the delivery of services. I remember back in the 80s when I was starting out that it was pretty distinct. If you had a mental health problem, you went to a mental health therapist of some kind. And if you had an addiction problem, you went to an addiction person, and they were really separate. They're coming together now, but it reflects the, in some ways, the lack of integration policy-wise in terms of how to harness our resources to address this. That stated, the reason I'm looking at the trauma and addiction models here is because in a simple sense, from a feeling point of view, all these pieces of somebody's brain who's just in their trauma / addiction, in their addiction, their parts are going wacko. They're not hooked up. It's in a fight, flight, freeze response. And so there's not an organized flow necessarily. It's much more complex and subtle than this, than I'm saying. But the sense to take away is that there's a disconnect, there's a disassociation to the parts, literally in the neuro and physiology of somebody's brain. So it's layered, both policy, brain, then the psychological sense of being disconnected, despair. There's no kind of hope. Go ahead, John.
So I think, again, we're trying to move through the nature of the problem fairly quickly and just highlight some pieces so that we can really talk about treatment. But it's important to understand that, you know, it's not just biology and genetics, that the environment plays a huge role in, you know, how these problems evolve over time. In Oregon, a lot of my work right now on Senate Bill 1041 is looking at a lot of kind of big picture factors of the addiction treatment system in Oregon. And some of you probably are aware of the social determinants of health and a lot of these different factors that play out in terms of trying to understand, again, you know, as a clinician, what shows up in the office. And you know, the picture on the right really, in some ways, tells the complete story. People that are homeless, that are on the streets, compared to somebody who can sleep at home in their bed, have, you know, very, very different experiences in their body, as Mark was talking about, even just starting with the sense of safety. So environment matters.
So now me just look, if we take in the homeless person, you know, being in Portland, you know, a lot of homeless people, especially in the downtown area. And I often think about how do they tolerate the anxiety that's in their skin. You can see it in their faces, laying exposed in the night, both the weather and both the threat of violence in some shape or form and the randomness of it. Who wouldn't do some kind of drug, drink alcohol to sedate, some methamphetamine to stimulate? But just, it's always fight, flight, freeze, kind of chronically stuck in our fight, flight, freeze response. And we're not built to operate forever at that level, but it gets stuck there. You know, people get stuck, and the physiology, the adrenaline, the cortisol, as we went through the brain scans, pictures as such, that it's on fire, chronically on fire. And then people, you know, they want to cope. In the short term, they do things to chill out, baby. Let's chill out.
Yes. The other thing that, you know, speaking about what Mark just said, is that, you know, the language we use with patients, I think, really matters. And one of the things that I have become practiced in talking with clients around this idea of addiction is really using more of the word adaptive, in that, you know, a lot of what people have been through in their life is a tremendous amount of suffering. And when people have suffered with adverse childhood experiences, with traumas, with things that really are overwhelming the body, with the defenses that people can handle, there's a natural sort of a process that occurs where people understand that various addictions, whether they're substances or behaviors, really are adaptive. They're ways of helping people to be in their body, to kind of continue to go forward in life, even though the body has had to survive something that was really unbearable. And so I, you know, people beat themselves up. There's tremendous amount of shame and stigma around these disorders. And the idea that they are adaptive is something that I try to get people to really understand in a real sense. I want to make just a brief comment about, again, yeah, go ahead.
If we go back to so environment matters, just to highlight this again. So if you grow up in a safe enough community where there's good education, the schools are safe, teachers are good, you have a stable family, you're not chronically in the family caught in an adrenalized or cortisol state, you know, routinely. You know the difference when you're in a crisis. You have safe, creative, substantive friends. The neighborhood itself is, you know, equal enough. It's mutual enough. People are respectful. It's not a huge class conflict. I'm not pushing Marxism here. It's not that point. But there's an equitable distribution, so everybody's kind of safe enough. Then developmentally, you can grow into your body. You can grow into your feelings, into your cognitive structures, into your imaginative structures, into your sense of body sensation and being intimate, connected to yourself. Then you can be connected to somebody else at all these levels. If that doesn't happen, years ago I worked in the state prisons in Massachusetts, and so really 97% of the people who were in the state prison system were essentially poor and into the system early.
I want to just make a brief comment about the fact that, again, we fragment disorders. The DSM is really the classic example of this. And even right now, as I'm mapping out the Oregon addiction treatment system, we really have a system that's built around, mental health and then substance abuse. That's been historic. That's not just in Oregon. But the point in this slide is again, the idea that as clinicians, we really need to see addiction and all of the various different objects of addiction as a package of behavior. And again, with trauma, there's a variety of different kinds of traumas that we need to be assessing. But in some ways, we feel a sense of control, I think, when we're able to diagnose and label. And yet, the brain doesn't necessarily do the same thing. All this stuff is kind of integrated. And so really part of this is setting the stage for moving into kind of this next part of this presentation around the fact that what we need are tools and ways of intervening with our clients that appreciate all of the addictions and not fragmenting them and just working with substances or just working with behaviors. We need approaches that address all addictions as a package in a similar way also with trauma, which is kind of where we're going.
The Body Keeps Score, big book from Bessel van der Kolk. The body keeps score. So again, look at the young boy in the corner. He's not fighting. He's trying to withdraw, but he can't. So you get the sense. We could call that he's freezing up. He's freezing up. And that, again, is the fight, flight, freeze response. If I freeze up, it's not conscious. They won't see me. I'll be camouflaged. And I start to dissociate. I'm not really there. Sometimes people faint. The reason is I get out of my body so it won't hurt so much. Then you get stuck in that place. I'm stuck. I'm stuck in my skin. I can't move. I can't work on that issue, et cetera. People say that all the time. So the stance is less cognitive. We're building a cognitive structure here. But at the same time, when you work with individuals or you're in a group with people working these issues, you got to speak to beyond their frontal lobes. You got to speak to their midbrain and speak directly in an intentional way so that they start to hear the tone of your voice, the position of your body, how you look at them, how you move your body. Are you a threat? And you start to elicit these micro states or more than micro states where people get cued in the interaction between you and your clients. I'm a psychoanalyst, Jungian psychoanalyst, so I'm always paying attention to the transference, countertransference issue. But in a simple way, how do people relate to me in an interpersonal way? How do I interpersonally, in my own skin, relate to them?
Last slide, and then we're going to move into talking about treatment. But in my experience, we in the field really focus very heavily on the pathology side of the equation. And we need to recognize that those who come into our office are a lot more than their diagnoses, their problems, their pathologies, that people have incredible creativity, talents, virtues, strengths. And in some ways, what I've found as a clinician is that working on that side of the equation actually at times gets me more mileage towards good outcomes that we'll talk about in a minute than focusing actually on the pathology side of the equation. Picasso said all children are artists. The problem is how to remain an artist once he grows up. And I think that's true that, little kids, they draw, they have absolutely no pretenses in terms of joking with each other and drawing each other's pictures. And yet, I think as we get older, we sort of educate ourselves out of creativity in many ways. The field of positive psychology is offering a whole lot of tools and ways for us to not only assess people's positive strengths and virtues, but also to work with those clinically. And so I think this slide is just, again, to kind of wrap up the nature of the problem, the idea that we need a balanced approach. When patients come in, trauma and addiction and all of these issues, particularly people who are struggling with opioids, and are injecting heroin. Yes, in some ways they are in a fight for their lives, and it becomes very easy to in some ways as a clinician, I have felt kind of the overwhelm with patients and kind of entering into their world in a way to try to save their lives. And I often forget that they're more than their addictions, they're more than their traumas. And yet it's important for me to continue to remind myself that, people are more than their problems.
So with that, the piece about how to elicit the artist within oneself, both as a clinician, that's why I'm a Jungian analyst, or a depth psychology approach, in the sense that the wound is the cure in the right dose. The wound is the cure in the right dose. Paradoxically, if I engage my despair, as I talked, if I engaged my inability to really grieve, to be sad, to be afraid, to be angry, to be despairing, to be shamed, if I have limited ability to connect with that because my ego structure is just so broken up from my years of addiction and trauma, if I can start to connect, help a client facilitate some entry into their suffering, that they feel me connecting to their despair in an affective and emotional way, just like a good mom would do with her child, or a good father would do, or a good friend, or a good lover, where we empathetically connect and we help them bear the unbearable. And that's the healing piece. It's really terrible. How can anybody deal with such acute despair, hopelessness, no way out, if there's not some felt sense that there's an alternative? So fundamental to the treatment process is a relationship where, both by what you say as a clinician, but really who you are in yourself. How do you handle your own affective states, your emotional states, including despair, with your ability to tolerate your own despair, your own sadness, your own grief, your own shame? Parallels, they're both connected. Both connected.
So to wrap up this part, the nature of the problem, the key takeaways really are, I think we are in the same boat, that, when our patients enter into kind of the clinical room and we're working with them, in some ways, we also have to pay attention to our own bodies, to our own histories. Mark talked earlier about, again, as a Jungian analyst, paying attention to sort of the psychodynamic transference and countertransference and the relational pieces of this. But we're in the same boat. I think as a field, we fragment these problems and we fragment our treatments. And so as we start talking about treatment, we're going to talk more about integrated solutions, integrated unified protocols for treatment. The body is incredibly important in this work, both for addiction as well as for trauma, paying attention to the body, being able to really sense when patients are sitting in front of us, even whether we might think that they're on substances, and then being able, again, in a safe, nurturing way, relational way, to ask them about, have they been using substances, not in a way to get them to run out, not come back and see us, but again, to create a framework for how to move forward productively. And again, last point, as I said, is we need to see our patients more than their problems and their pathologies. We need to really understand how to help them see a bigger frame of life.
So with that, so again, the piece about body, what's my body? What does that mean? So it's my ability as a clinician to engage and tolerate and work with, listen to my body sensations. Then the other piece, primary, is my ability to connect with my emotions. Again, my capacity to tolerate affect on a range: sadness, fear, happiness, shame, despair, anger. And so then you're paying attention to that in yourself. So then you develop that capacity to work with other people interpersonally. Good.
So we're going to talk now about treatment and give, again, realizing that we have limited time, try to put out a few ideas that you can take away and maybe follow up in your own work. This is it's an old quote from Stephen Covey. You might remember the 7 Habits of Highly Effective People. To begin with the end in mind means to start with a clear understanding of your destination. It means to know where you're going so that you better understand where you are now, and so that the steps you take are always in the right direction. So taking that forward, thinking about our clinical work, I want to walk through just quite quickly here, actually, how we think about treatment outcomes and the work that we do. And the model that frames the work is the contextual model by Bruce Wampald and his colleague Emil, and there's some other folks. The book is The Great Psychotherapy Debate. I think there's a second edition that came out in 2015. But the model says that good outcomes from clinical work, there are really two that we focus on. One is a better quality of life for our patients, and the second is that we help them reduce the symptoms that they're struggling with in their life: addiction, trauma, other co-occurring challenges. And these two sets of outcomes really come about through three change pathways. So if you look in the model and we back up, the three pathways for change are the clinical relationship, the expectations that we as therapists set with our patients by talking about the nature of the problem, and then the solution that we are essentially doing in our clinical work. And the third is the actual interventions, or what some people would say are the evidence-based practices. These are the three pathways. And in some ways, to even get into those pathways, it's that very first session. You have to have an initial therapeutic bond. Just like when you meet somebody new for the first time, we do read a book by its cover, and there's a lot of research to show that those first interactions are very, very important in that therapeutic bond. And again, not every therapist is right for every patient. So in those first few moments, if the bond occurs and it's strong and that relationship moves into a clinical relationship, we have these three pathways that really help us to understand outcomes.
So with that, talk about the real relationship. So I'm really, in the last 10 years, I'm of the school, I do a bunch of training, part of the Yale Institute in Portland here. And where typically when you assess people to come in to be a therapist, whatever tradition, that you look, how smart are they, more from a waist-based, their IQ, and can they do the bookwork really? Then secondarily almost is their empathy. But I'm increasingly of the school that what makes good therapists is their social and emotional intelligence out of the gate, and then how well have they developed that? Because then they're more, in an embodied sense, compassionate, including first with themselves, then with another person. So can't overestimate the quality and importance of the real relationship, that you relate to your client. You have a persona in the context, but you're a real person, because they need real experiences, positive connectors, literally in their neurophysiology, so that the dopamine, the serotonin is released, just like a good mother with a child, a good father with the good mother, where they set a frame for the kid. Dopamine, serotonin are banging, banging, banging. The good feel drugs that we create these unitive experiences so that people can deal with the quote negative feelings, their fear, their shame, their despair.
The research in the contextual model has shown that 65% of the variability in outcomes really comes from that real relationship. This is another way that people think about the contextual model, is the common factors model, that there are common factors, relational factors that contribute to good outcomes. The relationship is 13 times more important than the model, technique, or evidence-based practice used in treatment. So instead of spending our time talking about a lot of very specific treatments and specific therapies and models, in some ways, the very best that we can do is really understand, how to evolve our relationship with our clients. One way we do that is by providing them hope through enhancing their expectations for the future. And one way we do that is by getting good at being able to frame the nature of the problem, addiction and understanding again the nature of these issues, how they occur over time in the brain, as well as how they play out together, so that, as I talked about earlier, the idea that addiction is adaptive is really important in helping clients to reduce their stigma and their shame around what they've been through. Evidence-based practices, as you can see in the slide, is a small sliver, and it's not that they're not important; they're absolutely critical. It's just that the search for a practice that works better than another practice has really failed. What we have is a collection of practices that all work moderately well. So it's important to pick one, because you can have a real relationship and have good expectations for the future, but you still have to do something as a clinician.
So let me just say, so with that, so again, I'm not pushing everybody to become a psychodynamic psychotherapist. I can do a bunch of kinds of therapy because I've worked with lots of kinds of people over a long period of time. But that empathically, congruently, kind of with who you are as a person, what's your model? What's the model that you move from? That it's congruent with who you are as a person, and it's obvious in relationship to your clients, that they get, the way you're working is, well, that's Mark, or that's John, that's kind of his style. They may be different or some similarity, but the genuineness, the authenticity, the real deal. I mean, real deal begets real deal. Real deal begets real deal. That's deep. That's deep. That's really deep.
All right. Moving right along, who are expert therapists? I want to, age, gender, profession, theoretical orientation, adherence to treatment protocol. None of these predict expert therapists. The people who really get the best outcomes, again, really learn how to fine-tune those three pathways. So pathway one is the relationship. Tim Anderson talks about facilitative interpersonal skills, the ability for us to instill hope in our clients, verbal fluency, persuasiveness, emotional expression. These are all the things that Mark has been talking about relationally. Pathway two, again, is this idea that we have to get good at being able to really talk with our clients about the nature of the problem and the solutions that we are offering in a way that they buy into and that they appreciate, and that we can then actually deliver the intervention. If they're not buying into the way that we frame the problem and the solutions that we offer, we can have the very best evidence-based practices, but they don't get very far. The last piece on the right here is this idea that as therapists, just doing therapy, there's not research that suggests that we become better therapists. What makes us become better therapists is really evaluating our work, both formally and informally. We can use tools with patients. Scott Miller's called this feedback-informed treatment. I use the outcome questionnaire 45. I give it to patients once a month. I look at their scores. But the other is that we also videotape sessions. We show our videotapes to our colleagues. We get feedback on our blind spots, and then we practice those blind spots. Again, going back to, what is it in those three pathways where we need to practice? But it's really about deliberate practice. We get better at getting good outcomes by really honing in on what we do well, what we don't do so well, and then practicing those blind spots.
So again, with that, the weight is on path one. And again, how I would experience that would be social and emotional intelligence. And you, the clinician, deliberately developing that. Hopefully you got enough of that so that you're in the game to begin with. And then practicing your own emotional intelligence, your ability to identify, to tolerate, to work, to bear, and use your own feelings, your body sensations in connection with other parts of you, like your imagination, your cognitive processes, your memory, so that you can connect to these pieces in yourself. If you can do that, then you're in relationship with somebody who you're practicing the same thing with them. That's the nature of trauma, where these things go sideways. The path to the problem solution focus is aspects of the framework. How do you frame your ability to emotionally connect with somebody? You need some cognitive structure, i.e., I'll see you once a week, I'll see you twice a week. We got to work on your sobriety, because you can't relax enough if you're always getting high. And so then we work on cognitive structures, what are the things that they can hang their hat on to get a relapse prevention model. That gives them a base. But then, my estimation, then you got to go after the feeling, the emotions, what's fueling the fire of the behavioral addiction, the chemical addiction.
So I want to talk a little bit concretely about assessment, and then some specific, so this is again sort of pathway two, and then we'll talk a little bit about some of the actual practices, and then we'll take some questions. I've experimented in a variety of ways at how to assess clients, particularly that have a whole host of issues coming into session. Again, trauma, all of the different addictions. And I've landed on kind of creating a comprehensive behavioral health self-evaluation that works for a majority of clients. Some who, again, are less functioning, and I will work through this evaluation with them in session. But for the majority of clients that can read and write, this packet has a variety of validated assessment tools. I'm going to make this packet also available to all of you. You guys can download it, but I'll make sure that you get a copy of it. And it's a Word document, so you can go in and cut and paste and do whatever you want with it. But a lot of the validated tools in there they're all in the public domain. For trauma, I use the PCL-5, which is a VA tool, 0 to 80. There's kind of a cutoff score around 33, and it's a tool that can be used more than once to assess trauma. I also have in here assessing ACE score 0 to 10, so I have an ACE score. The other thing is that also looking at the fact that many of the patients that struggle with trauma and addiction also struggle with a version of insecure attachment. We didn't talk a lot about, or at all really in the beginning, about attachment, but in the general population, about 40% of people have a version of insecure attachment. But in terms of clinical populations, people showing up with trauma and addiction, it's much, much higher. And in some ways, John Bowlby, the father of attachment theory, has said that, in some ways, attachment is cradle to grave, and it influences the ability for people to initiate, form, and really have healthy relationships. Attachment is in place somewhere around 18 months of age. So again, people don't have a lot of say in the attachment style that they end up coming out of the gates with. Nobody is destined to maintain their attachment style, though people can earn secure attachment through some interventions we'll talk about in a minute. But the idea with this evaluation is that patients fill out the packet, they come into session, and then it's very relational, that part of building that hope for the future and increasing and enhancing the positive expectation is going over the results of these different tools and putting a complete, as best as possible, picture together of what a person's been struggling with. My experience has been that very often, patients struggle with disintegration. We've been talking about how all of this creates fragmentation within people. Not only their psyches and their bodies are fragmented, but we fragment all these disorders. So having a comprehensive evaluation where you can sit with a patient and then relationally go over the results in a session, sometimes 2 sessions, and really use the session as putting the kind of the puzzle together. And at the same time that that's being done, checking in with the body. I ask patients, what's your experience right now? Just sitting here as we go through this evaluation. What are you noticing in your body? And then processing the emotion that comes up as we go through the evaluation. But very often, at the end of this session or a couple sessions, the whole goal is to enhance the motivation and the hope for the future that, we do have tools and strategies and practices that can help people overcome the picture that we frame in the evaluation.
So with that was well stated, John. So the piece about motivation, motivational interview and motivational, how do you build motivation? Again, I'm of the school, affect is king, emotion is king. Emotions put us in motion. And then typically when people have trauma, again, sort of, complex trauma, simple trauma, complex trauma, developmental trauma. We're talking mostly here about developmental trauma, long-standing, and also complex trauma in substance. But it's a problem of affect, body sensations, that they get separated from thoughts, cognitive structures, memories, images. And then when they do connect, they come back in grand relief with lots of pain. And then people dissociate because it's overwhelming. They do weird stuff compulsively to try to, as John says, protect themselves. It's adaptive. So the ability, again, so two big takeaways I want to communicate. One is the wound is a cure in the right dose. So you have to work people's wound. Trauma, in the end, in the Greek, it means wound. Big wound, little wound. We all got trauma. We all have wounds. How do we handle our traumas? And the right dose. So when we work with people in their body, with their body sensations or emotions, we're eliciting that state to come up in the session, just like a good mama would, just like a good daddy would with a child or an adolescent. the other piece is, what's the seed? What's the creative seed that's trying to come out of the wound? It's not just reductive, it's all bad and it happened back and I just got to get behind it. There's some kind of push that's trying to come out, some creative piece, that we had to quote from Picasso, etc. What's the seed that's trying to manifest?
One of the things too that has happened with this evaluation tool is with clients that say do the PCL5 on trauma. It's happened many times that a patient will score a 0 or they'll put a 2 or 3 out of 80, like they have absolutely no trauma. And then in a recent session, I had a client tell me about when he was 10 years old and his mother put him in the car. And in this particular part of town, there was a cliff. And so she said as they're driving towards the cliff that they're going to be better off after the car drives off over this cliff. And he's saying it in a matter-of-fact way. This is a guy who put 0 on his PCL5. And I said, well, what were you thinking? And as they're driving in this car racing towards this cliff, he said, I was really pleading with my mom not to drive over. And I was thinking in my mind, I'm going to jump out of the car before the car goes over. And he said, fortunately at the last minute, she decided not to do it. But again, when I, in the assessment and asking him, was this traumatic? For him, it was absolutely not traumatic. But again, if you think about the body keeps the score and what happens with the body, in order for him to survive this moment, in some ways he had to shut down. He had a freeze response. And I think in some ways, part of the challenge we have right now with the opioid epidemic, if you think about it, is that when people have trauma and they go into the freeze response, part of that freeze response is natural opioids flooding the body. And I think, there is a connection to the fact that a lot of people right now that gravitate toward pain pills and heroin, opiates, are able to reconnect with an experience of freezing. I don't hear a lot about that, but there's absolutely a link between the freeze response and the opioid epidemic, in my opinion.
And I would say, from a phenomenological point of view, being around somebody who's high on street heroin, that's what they look like. They start to nod off, and they're soothed, at least initially, and they're kind of frozen. They're stuck in place. They can move, etc. So it's not a true freeze in the classic sense, but it's a response to too much stimulant. In the end, that blunted or flat affect is not the absence of emotion or body sensation. It's not the absence. It's too much. And so the brain, the central nervous system, compensates by flattening, blunting affective response. You see that all the time. Street people, hardcore addicts, you see that in the prison population, high-end military operatives, etc. So affect, follow the affect, follow the emotion.
We talked earlier about the problems really being again, kind of a combination of the biology, the genes, and the environment. And so our treatments really have to appreciate both of those as well. And as clinicians, when working with trauma and particularly working with addictions and right now with opiates, being familiar with the arsenal of addiction medications is very, very important. We don't have time to go through all of these. I assume many of you are aware of these different medicines, but if you're working clinically with patients that have addictions, understanding these different medicines, the benefits, the risks, and the costs, and learning how to talk with these medicines with patients is absolutely critical. Many that are struggling with, opioid use disorders are going to make little progress until their brains get stabilized enough through medicines to be able to do the deeper work of trauma that, Mark and I have been talking about. Want to talk briefly about 2 protocols that you may or may not be aware of. Again, we have limited time, and we want to have give you some time for questions. But the 2 protocols, one is Dan Brown and David Elliott's work on treating attachment disturbances. This book came out in 2016. You can go to a website, the Attachment Project, where you can learn more about this. But in our experience, the majority of clients that we work with have attachment disturbances. And in some ways, part of what I've learned from working with Dan as one of my mentors is that clinically, we treat the earliest disturbance first. Now, clearly, if people are coming in and they're high on drugs or using alcohol, people need to be detoxed. We need to work with that piece first. But when people are stable enough to work with clinically, usually I start with attachment. And the very best protocol that I have come upon to really help people remap their attachment systems is the 3 pillars model of comprehensive attachment. The idea has been in the past that our relationship in therapy can kind of repair these attachment problems, but 1 hour, 2 hours a week is not enough. And so this model is really one that uses the imagination, and that we create these idealized parent figures that can remap attachment within 3 to 6 months. It's very, very powerful. If you're not familiar with Dan Brown's work or with this particular protocol, part of it is just making you available and saying, I encourage you to go and look at this work. On top of that, once attachment has been addressed, then we're really talking about, and again, we've been talking about these 3 pathways, assuming that you have a good relationship with the patient and you've been able to kind of express the problem and the solution. Then it comes down to that 3rd pathway is, what do we do? And I have been working more and more with the Unified Protocol for Transdiagnostic Treatment of Emotional Disorders, developed by David Barlow and his group in Boston. This is one protocol that treats all of those different disorders up there: PTSD, OCD, panic, GAD, social anxiety. It treats all of them with one approach, which to me, again, is leveraging my time, my resources. In addition to these protocols, there's also workbooks for clients that they can use. So there's actually homework and things that clients can do on their own. And the feedback that I've gotten from clients has been really phenomenal with this approach. If you're not familiar with the Unified Protocol, there's a website, you can check it out. But in some ways, these 2 resources really have kind of been the backbone of that 3rd pathway of, when somebody says, okay, you form a relationship, you have the expectations lined up, what do you do now? These 2 resources would be what I do.
So with that, you can see the tension, and at best, it's a creative tension between kind of the prescriptive approach, based on data, and thoughtful reflections on the nature of the problem. How do we intervene with these problems? But again, I push. I'm a thinker, so I like all this conceptual frameworks, but that it's you as a clinician. And so then how attached are you in your relationships? How attached are you to yourself? And so then, there's a classic depth psychology point of view. You really can't go farther with your clients beyond where you are. And you can stretch that, but push comes to shove in a long-term psychotherapeutic relationship. I think that's substantively true, because on the lesson I teach, in my self-expression to my clients, again, in that framework, my ability to tolerate affect, work with it creatively, hooks up to my imagination. We're built to be creative. And then how do we get creative? And, these are huge puzzles, and they're way beyond, in some ways, our strict cognitive frontal lobe's ability to organize and put a plan together. So we have to really connect to the brain, central nervous system's capacity to hyper-develop in what are the circumstances where development happens.
So I'm aware of the time. Last 2 slides. Just want to comment that both Mark and I, in working with patients, in some ways share patients. We do individual. We have other colleagues that we work with that do couples counseling. We put clients in men's groups and women's groups. We work with medical professionals on medicines, on doing psychiatric evaluations. If there's anything cognitive, traumatic brain injury, we work with physicians. We're very supportive of self-help groups, the 12-step community, as well as other, smart recovery, and using the community as a support. I frequently refer clients to yoga studios, to dietitians, in some ways encourage clients to explore theater and cooking in a creative way. It takes a village. So that kind of wraps us up. We're in the same boat. Our overall goal is to try to help clients integrate We also want to focus on not only helping clients with what they struggle with in life, but also their strengths and their virtues and assessing those. And again, this is tough work, so practicing self-care. Practice. All right, we have a few minutes for questions. Bia, are you taking that on?
Yes. So let's move here. Okay, a minute. Okay, so I can. So this is the contact information of our speakers. Thank you so very much for this very interesting perspective. We are now open for questions. Please type your questions in the box. Meanwhile, we depend on your evaluation, and we really appreciate if you take a moment to respond to our 2 short surveys. One is going to be sent right now, right after this, and the other one is sent in a month. We want to get better at what we do, and we need your feedback for that. And you even get a $5 gift card when you complete each of any of these surveys. So it's your cup of coffee right there. We also would like to remind you that we have a webinar on the 4th Wednesday of every month. So our next webinar is going to be about expert model for teens. Please join us too. Okay, so we have one question here for how long after the detox would you recommend starting the process of trauma work?
This is John. I would say, detox isn't treatment, and very often, people will go through detox and then sometimes fall through the cracks and not get treatment. So, in some ways, following detox, really the very next thing is to focus on the stabilization specific around the addiction, so somebody doesn't relapse. And so, normally I think an appreciation of the role of trauma, building in that expectation and helping people to understand that at some point, the reason why addiction has been a problem in their life is that adaptive nature to what happened earlier on, whether it's attachment, trauma related. And so I start the conversation very, very early, right there in the assessment. But when it comes to the actual, treatment, for me at least, it starts around the education piece. But actually working with trauma and bringing up memories and working with the body comes much later. Probably, could be months later, but not right after detox.
Yeah, and again, you're doing an assessment. What's the degree of the detox? How pervasive was the use of the behavior or the chemical use? What was the effect function on them in the community? So again, bottom line for me is you use your empathy. I mean, it's informed by practical experience. But in detox, as John says, it's detox. It's not treatment except to start to build a frame. So what's the quality of the frame in their day-to-day life? Do they need then, further treatment in a residential setting? They need to go to an intensive outpatient program. So you're making these judgments like you would with a child or adolescent or somebody who's recovering from surgery. You don't do PT for the first 2 weeks after, knee replacement, but you base it on the specificity of the person's state who you're treating.
Okay, well, thank you very much. We are 2 minutes to the end, so I'm going to try to get one more question here. A question is, what would you say would be the best therapy on the area of being creative for a person struggling with addiction?
So for me, once they're focused, actually what I do typically, and I learned this in my Jungian analyst training, but it's a staple of play therapy for kids, is draw pictures, spontaneous pictures. It's a way to bypass the frontal lobes, including with artists. So you can say even where you ask them to use their opposite hand. It's not about craft, it's about symbolic process. You're bypassing frontal lobes and substance, and you're getting into the amygdala, to that imaginative reason. The first time I did that, back in my early 20s when I was seeing a Jungian analyst for the first time, he asked me to draw a picture. I was like, whoa. And I drew the picture, and the picture that I drew was a dumpster, and I was in the dumpster. And so the tale begins. You know, that's been a guiding principle. Now I work with people's dumpsters.
That's very interesting. So we have way more questions that we can answer, but I want to remind you that this webinar is going to be up as soon as we finish this, and then their emails and contact information is in the slides, and you can email them, and they may have the opportunity to respond to you. We can assure you that. So again, thank you so much for today. We really appreciate the opportunity to hear from you, and thanks for attending, all attendees. We had a record number of people joining us today, and talk to you next fourth Wednesday of the month. Thanks.
Thank you.
Thank you, everybody.